Hello again, farm friends. Dr. Bratt, and here's another chat with Bratt about drugs to treat diabetes. And this is the second presentation in relationship to drugs to treat diabetes. And in this one, we're going to explore a little bit more deeper about Mrs. Waller and how we're going to be using drugs, particularly insulin, to treat her type 1 diabetes. So she's basically been, after she was stabilized in the ED, she was put on a regimen of taking insulin glargine 55 units once daily and Lispro insulin per blood sugar correction 3 times a day. And this is a pretty standard way in which we can treat diabetes because it really does provide good coverage for the patient across a day. So when we think about this, is what we're trying to do is we are using a combination of insulins. And this is going to be the focus of this presentation. We're going to be talking about the major types of insulin. So there are 4 types of insulin that we're going to be discussing. And the first one is regular. Second one is NPH, Lispro, and glargine. So insulin is insulin. It doesn't make a difference what type it is. It basically is insulin. And what it's trying to do is it's trying to take glucose out of the bloodstream and put it into the muscles and into the body where we need it. So how they differ, though, that's the important thing about this slide, is that they differ in their onset of action, in their peak action duration. Onset's important to know because that tells us when that particular type of insulin is going to be starting to work. And so that's critical to know because we need to time that in relationship to the patient's eating. So regular insulin is going to have onset of 30 to 60 minutes. It peaks in 2 to 4 hours. The peak is important because that tells us when that drug is going to have its maximum hypoglycemic effect of basically taking glucose out of the bloodstream and putting it into the cells. And you can see here duration is important to know because that tells us when we would need to redose the patient because it only has a certain amount of longevity. So those things are important to know about your insulin. So regular insulin is a basis, and it can, again, onset in 30 to 60 minutes. So that makes certain that that's the time the patient needs to eat within that window. NPH insulin is the second one, and NPH has a little bit longer onset of action, and you can see it peaks a little bit later and it lasts a little bit longer. So it can be common to give regular insulin and NPH insulins together. And because they're going to have this ability to monitor or address blood sugar over a course of 24 hours. 2 other insulins that we're going to talk about is Lispro. And Lispro, you can see, has a much shorter onset of action. So this one is a rapid acting, and you've got to make certain that patients eat very quickly after this insulin is given. And you can see here it peaks. Again, this is going to correlate hopefully with mealtime. It's peak hypoglycemic effects, and it's got a short duration. So you can see right from here that this insulin is going to need to be given more frequently, and particularly in relationship to meals. And the last one is glargine. And glargine, you can see, has a longer onset of action. It has no peak. It has this constant ability to maintain glucose levels, and it can last for 24 hours. So this information is helpful because you can see when you need to give insulin, what the insulin is doing, and when you need to be monitoring patients for hypoglycemic activity, and how long it lasts so you know when to redose patients. So just a little bit more information about the short acting. We talked about the Lispro, which is a very rapid acting insulin. Again, this is very important to give within 15 minutes of meals because that's when it starts to work. But you have to remember that if a patient doesn't eat, you're going to see hypoglycemia at about 30 to 90 minutes after giving this if the patient doesn't eat. The duration is 2 to 5 hours, so you've got to remember that has to be given again when the patient eats. It can regular insulin has a little bit shorter onset of action, is 30 to 60 minutes, and this one you can give again because the onset of action is that you need to feed that patient or provide meals for that patient in that 60-minute window. Otherwise, the patient is going to have problems with hypoglycemia. Again, you can see that it peaks in 2 to 4 hours, but it can last up to 6 to 12 hours. So those are important things, and that's what distinguishes those types of insulins. So let's look at a next type. And the next one is what we call intermediate duration. This is NPH. The unique thing about NPH, if you take a look at the vial, it's cloudy. And you can see here that the onset of action is delayed. It's hour and a half after injection. So that helps to maintain a glucose level past the mealtime and into the rest of the day. It peaks within 4 to 12 hours. And again, it can last up to 24 hours. So this can be combined with regular insulin to provide 24-hour coverage. Now that's contrasted with the long-acting insulin. It's also called a basal insulin, and this is insulin glargine. It's also known as Lantus. And if you look at the vial, it's clear. And take a look at this one. Its onset of action is about 60 to 70 minutes, but doesn't have a peak. So it's just this constant ability to maintain blood sugar. And that's the cool thing about it. The other thing you need to remember about this is that you never mix it in a syringe with any other type of insulin. It has to be given in its own injection, and that's a critical point. And the reason for that is, if physiologically, if you just look at how this insulin works, is that when we give it, it creates kind of these precipitates, these crystals, almost like underneath the skin. And what happens, those kind of slowly dissolve over time. Kind of like if you've ever taken an extended release tablet that slowly releases over time. That's what insulin glargine does, is it helps to slowly release the ability to moderate the glucose levels over a long period of time. So this is a great insulin to give patients once a day in conjunction with one of the rapid acting. So when you compare these types of insulins, and that's the cool thing about this diagram, is you can see why sometimes we can combine insulins, because sometimes we can combine a short acting with a longer acting. We can combine a very rapid acting with one that has a more of a long duration. And that's a really nice thing about it, is that because we're trying to, again, always with these types of insulin, we're trying to mimic the body's normal production of insulin based on carbohydrate intake and based on what the body's needs are. And that's what we're trying to do with insulin therapy. So keep that in mind. So there's lots of different ways in which we can give insulin. We can, commonly it's given through a sub-Q injection. We try and use any type of subcutaneous tissue that we can easily grasp and kind of pull together. We can use pen injectors, these jet injectors that kind of inject insulin through high-powered pressure into the skin. We can use pumps, and we can give it IV. So when Mrs. Waller came in and she was in ketoacidosis, we gave her insulin via IV. She might be a good candidate for an insulin pump. And that's really nice that we have these options for patients that have diabetes. So if you remember, this is just a way that we give sub-Q injections. And again, you do that by swelling the tissue. We don't want it to be getting into the muscle tissue. We want it in the fat tissue so we can get that slow absorption. Right? We can give insulin in a lot of different locations. We again try and look at the areas in which we can grab a handful of tissue and swell the tissue so it stays in the sub-Q. And this just shows you what ideal insulin therapy is like. So again, we're trying to mimic the body's normal peaks and valleys of insulin production so we can maintain not these wide swings of blood sugar. So again, if the glucose levels go up after the patient has breakfast, we want the patient to have some insulin coverage to deal with breakfast. Again, when you have lunch, next time you eat, you want insulin to be given so it can mimic, again, the body's normal production of insulin when you eat at lunch and again at dinner time. So just keep that in mind so you can understand why we mix insulins and why patients might need multiple injections of insulin over time, because we might need to dose them in the breakfast, before lunch, and before dinner, and also give the patient a basal insulin. So that is not uncommon. So one of the ways that we basically can make certain that patients are on track is the best test that we have is by the glycated hemoglobin test. And the cool thing about that is it really gives us not this right here and now what the blood sugar is. It tells us what the blood sugar has been in the last 2 to 3 months. So it tells us what happens over time. So even if the patient comes in and says, you know what, I'm under control, well, we really find out with the patient's under control whether the hemoglobin A1C is within normal limits. And we really like it at about, example, we want it to be at between 4 and 6%, okay? And that's what's important to be monitoring for patients who are on insulin therapy. Because again, it gives us that best idea to know if they're staying in control over time. And that's what our goal is. So one of the biggest effects of insulin, side effect, of course, that you can't forget, is that it causes hypoglycemia. So this is a side effect of insulin, and it results when patients get insulin and don't eat carbs. So how are we going to deal with hypoglycemia? Give the patient carbs, right? Because that's the problem. So these are just a couple quick ways in which we can get carbs into a patient, and this is important for you to know as a nurse that we can treat hypoglycemia in this manner. We can also give patients glucagon. And this is something that if patients are having trouble keeping their blood sugar within control, they might have a syringe of glucagon in the home. And if they can't ingest quick-acting carbs, this is a way that we can give glucagon. Again, it's going to promote the breakdown of those storage forms of glycogen from the liver, and it's going to help to increase blood glucose levels. Okay. It takes a little bit to work, and so again, you got to get that glucagon into that patient as soon as possible to get those glucose levels up where you want them. Okay. So some nursing considerations. Remember, we need to identify patients that are high risk for altered blood sugars, and those are the times, again, patients who have taken their insulin and have not eaten. Patients who have been working out a lot and not eating, they're going to be at risk for altered blood sugar. So they're going to have problems with hypoglycemia. So you're going to see, so think about those symptoms, is that this rapid, sympathetic nervous system stimulation. I think many of you might have become hypoglycemic and you feel really lousy. You're sweaty, you need to eat, you get crabby, and these are just kind of some of the key signs that we might have when we are hypoglycemic. So here are some key points. Some key points about insulin is that we need to monitor the patients for hypoglycemia at peak times. That's when that insulin is working at its highest level to take sugar out of the blood and put it into the cells. You have to be very careful, and this goes into your teaching with insulin, is you need to balance exercise with glucose intake. And you have to make certain exercise helps the cells to take up glucose. So if you're taking up glucose and you aren't eating, that's going to be really difficult. So you need to balance that. Okay? You can take insulin while pregnant. It does not cross the placenta, and we need to keep mom's blood sugar within normal. But we have to realize that we might need to adjust those doses. Drugs, the biggest one is beta blockers because it blocks that sympathetic response to low blood sugar. So it kind of negates the person who is hypoglycemic to know that he or she is hypoglycemic. So it's important that we avoid beta blockers. If you mix insulins like NPH and regular, you need to administer that client within 15 minutes because it will lose its stability after that. And never mix glargine with any other type of insulin. So those are just some key points. So stay tuned to part 3 where we talk about drugs to treat, oral drugs to treat diabetes. See you soon. Bye-bye.